enhancing the provision of care in rural areas, breaking down that sense of urban metro divide, the haves, the have-nots. Police, particularly in rural areas, often have police services. Why can't they carry AEDs and respond? Recognising equity actually requires you to do things differently in rural and regional Australia than you would do in urban areas. The outcomes can still be the same, but you have to think differently.
How can data and predictive analytics, how can that help support new innovations or help bridge that gap?
It's thinking outside the square and harnessing what you've got in those communities to deliver, not trying to replicate what you've got in an urban area because it just doesn't work.
I just love this conversation about Western Australia because all I can think is that there's nothing like this little bit of rivalry that we all love. Welcome to Ambulance Insights, your go-to for the latest conversations covering all things ambulance, and I'm Lindsay Mackay.
And I'm Hanwei Lee, and this is the Great Divide series, where we tackle one of the biggest challenges in the pre-hospital care setting, bridging the gap between urban and rural ambulance services.
Each episode, we bring in experts to share their stories and spark conversations that matter. So wherever you are based, that's one for you.
Today, we are really honoured to speak with a really distinguished guest with nearly 4 decades of experience. Our guest is a leader in emergency medical services and a passionate advocate for first responder wellbeing. His contributions to ambulance services and resuscitation have been recognised with numerous honours, including the Ambulance Service Medal and the Heart Foundation President's Award. Since retiring from Ambulance Victoria, he's remained actively engaged as an academic management consultant and a non-executive director of a number of non-for-profit organisations, allowing him to continue his passion for supporting the community and improving emergency medical services.
Welcome, Tony.
Thank you very much.
I would say welcome, Tony, ESM, but I think that doesn't matter in this room. I've never been in a room with so many ESMs.
That's true. That's true. It's very true. Yes.
Welcome. We appreciate you coming in. You've had an amazing career, and we definitely appreciate you coming.
No, thank you. Thanks for the opportunity.
So, if we dive straight into this, so our podcast theme is around that great divide. Now, we aren't just talking about geography here for everybody. It's really about that. What is the very real differences and how is care delivered? How is it accessed and experienced? Really depending on where you live around Australia.
We're talking about the gap in resources, response times, workforce availability, technology, and even patient outcomes between metropolitan and rural or remote communities. Today, we want to look at equity and how we can bridge that divide to ensure everyone, no matter their postcode, receives the care they need. You'd just be interested, Tony, to get your view on the Great Divide as a whole, maybe either relevant to what you did in Ambulance Victoria or now on multiple boards and committees.
Yeah, well, it's a really interesting topic because nearly a third of our population live in rural and regional Australia, and as a result of that, their expectations around services are very similar to people in Melbourne, and other urban cities around Australia. So you're dealing with people who are looking for a similar experience, particularly sea changes and tree changes. People have moved out into those areas. But the ability of ambulance services to deliver those services the same way they would in, say, the middle of Sydney versus doing it out in outback Australia is obviously different. And so it's, in my experience, it's about, one, recognising equity actually requires you to do things differently in rural and regional Australia than you would do in urban areas. The outcomes can still be the same, but you have to think differently. You need to harness the incredible community that exists in those areas to be part of the response system more broadly. And importantly, also being open to different ways of delivering services. So engaging in, just a quick example, in one of the times in my time at Ambulance Victoria, we worked with remote area nurses and volunteers who were not able to give effective pain relief. Penthrain most listeners would be aware of, it wears off after about 20 or 30 minutes, and so what's next? And so they might still have another hour till the ambulance arrives. So we worked through a process of implementing intranasal fentanyl for volunteers and remote area nurses who are operating as part of our system. Now, if I tried to do that in the middle of urban Melbourne, I'd be having some pretty significant conversations industrially and with other professional groups, and et cetera. But in rural and regional Victoria or rural Victoria, it was actually okay. And, we put in strong clinical governance around it and they were delivering really effective care. And I remember One case in particular, 2 or 3 hours in the high country of Gippsland away from the nearest ambulance, a young kid had fallen into a fire, serious burns. We had a remote area nurse who was there in around 30 minutes who was able to give effective pain relief, support that child until help arrive with road and air ambulance. So again, it's thinking outside the square and harnessing what you've got in those communities to deliver, not trying to replicate what you've got in an urban area because it just doesn't work.
Yeah, most definitely. And I think kind of what resonates there with me is that, especially with your time in Ambulance Victoria, you were always wanting to continually innovate and think about, things that some people would say was a bit different,
yes.
Right? And then when you look at it, Ambulance Victoria is leading in cardiac arrest outcomes. And really to kind of set the scene, can you kind of describe how cardiac arrest kind of typically differs between that urban and rural?
Yeah. If we take a step right back, we know that people living in rural areas around Australia have worse outcomes for cardiac arrest. A landmark study done by paramedic and other researchers around Australia last year highlighted the fact that, the areas that have the highest rates of cardiac arrest, the lowest levels of CPR, are in rural and regional parts of Australia. So that creates an equity straight away. The reality of cardiac arrest in an urban area is, someone dials 000 in certainly the metropolitan area of Melbourne as an example. You're getting a first responder potentially activated by Good Sam. You're getting a firefighter co-respond program. You're getting somewhere there usually in sub 7 minutes, and then backed up pretty quickly by a paramedic crew and by intensive care paramedic as well. So you get the if you like, the gold-plated service. If you're in a rural area, then, the reality is you may or may not have access to a first responder that's near you. The fire services may or may not be part of a co-response model in those areas. So you're waiting for the ambulance to arrive to activate care. And so that activation of care could be an hour away. And so we all know that there's a 10% reduction in survival for every minute that someone's in cardiac arrest. So just doing the sums, the likelihood of someone surviving in those areas is low unless you've got a system that can provide that support. And if we look at the things that make a difference, if we look at, the chain of survival and, sort of all those links in the chain are not equal. If you look at the evidence would suggest that, actually highlight that the best outcomes occur in those settings prior to ambulance arriving, and ambulance makes a difference as well. But beyond that in the chain, the studies don't demonstrate a significant change in outcomes. So it's what happens prior to ambulance arriving and when ambulance arrives that makes the difference. And so how do you therefore say, well, if we know what improves survival, what do we need to do about it to actually replicate that in a different way, maybe in a rural regional community than we would in the middle of an urban city?
Yeah, it's interesting, Tony. I think for all those reasons you've just highlighted, out of hospital cardiac arrest, the rates of survival to discharge are 50% lower in rural versus metro areas. You talked a little bit about, I guess, that tyranny of distance. Yep. What do you think the other drivers of that gap in the rural remote areas are?
Yeah, well, it's a really, really good question. If we look at just the health outcomes more broadly, they have by default often lower access to primary health. GPs, can often have untreated comorbidities that can worsen the risk of cardiac arrest, and they aren't necessarily surrounded by people who can support them when an event occurs. So the reality is that their health indicators are more likely to lead to a cardiac arrest than you would see in, say, urban areas where people have got better access to primary health, better access to messaging and other things that maybe not exist in some of those rural areas.
I think when you think about nowadays, some of the stuff we're trying to put in place. So, we've obviously got big campaigns on AEDs. We've got things like Good Sam. And obviously you introduced Good Sam to Ambulance Victoria. What do you think that role of community responders and Good Sam type programs will really help in bridging the gap in those communities?
So I think it's critical, absolutely critical. And it's interesting, if you look at the cardiac arrest outcomes more broadly around Australia and internationally, we often put Seattle up there as the penultimate place. I mean, the reality is the response frame of Seattle is essentially the size of the Melbourne CBD. Well, and they're getting around 51% survival from cardiac arrest. You look at Victoria with 41%, that's for the whole state. Now, interestingly, WA, one of the biggest land masses in the world, actually, its survival rate is 40% for the whole state. And if you look at that and think, well, no, that just must be Perth. It's not. It's the whole of the state. Why? because what you end up with is community response occurring to support that early defibrillation, early CPR. So I think often there's a sense that ambulance services need to own the complete response in every community. The reality is ambulance needs to govern a system of care, a cardiac arrest system of care. So Good Sam is a great example. No ambulance service can afford or have the resources to provide a sub 5-minute response. But if you look at the best outcomes in cardiac arrest, you're getting early CPR and early defibrillation in that first few minutes, that first 5 minutes. So to systemize that, in my view, that's where products like Good Sam, Pulse Point, the St John WA app, and similar sorts of products that are used around the world and make the difference. So what you do there basically is that when someone dials 000, first step number one is someone at the end of the phone is actually helping them know what to do, to guide them to do CPR. That's the first thing. The second thing is that they're immediately dispatching a responder. In Victoria, that's within a few hundred metres of a cardiac arrest. In rural areas, it's within 5 kilometres. But what you end up doing there is basically saying, well, you've got a system now that if you can hang more responders on that app, you can hang more AEDs on that app, then what you're really doing is replicating what you're seeing in urban parts of Victoria, Melbourne and Sydney, or around Australia, major cities, into those rural areas. And I think one of the great things that organisations like Ambulance Victoria have been doing is the Heart Safe community program, which again is walking into a rural community, because if you visited one rural community, you've visited one rural community. It's not homogenous. You can't replicate what happens in this town. In this town, just doesn't work. So how do you walk into that community, find the leaders in that community, get them engaged in how we as a group improve cardiac arrest in our response area, our town, and then focus on increasing the numbers of people trained in CPR, getting them signed up to Good Sam, increasing the number of AEDs. And again, if you look at the St John work at the moment in defib in your street, in the communities they're doing that, acknowledge in Melbourne, they're getting defibrillators that are 3 minutes walking distance from people. So in towns, you can do that. As you move out to properties and larger properties, it's about saying, well, actually, the principles are the same. A colleague of mine who's got a AED on his front fence of his property, and everyone around knows where it is and people are trained up. So again, you might not get them there in the 5 minutes, but you can get someone starting good CPR and you might be getting an AED there in 10. And again, gives them a better chance because that ambulance might still be an hour away. So things like Good Sam really, in my mind, are the Tyler binds. They're the thing that basically enables you to have an army of responders built around what your community, and we're talking about rural and regional areas of today, but equally it could be a block of flats, a tower, and that's the community. So defining community and then working out how you best create a response within that sort of 5-ish minutes then allows you to do something different there than you might do over here.
It's interesting you brought up the King County, which we all cite and have done for probably the last decade.
Yep.
They're the pinnacle of survival rates. And, I guess I probably didn't really think about that, the fact that the 41% for Ambulance Victoria in the last few VACAR reports actually did cover the whole state and Western Australia as well. How do you think, besides Seattle King County, how do you think we compare to other countries? I think
there's still a bit of a haves and have-nots in cardiac arrest, even in Australia. So, we've got some pretty significant differences between the ambulance services that you would argue on all accounts should be relatively equal, even in urban areas. So I think where you leave it to chance, where you bought defibrillators, we've got some community CPR programs, and then all of a sudden, you have the odd survivor and everyone gets really excited about the fact we're doing really well until one day someone looks at the data and goes, well, actually, we're not doing that well. And I think if you look at the work the Global Resuscitation Alliance has been doing internationally, built on the work that came out of Seattle King County and the Resuscitation Academy, is very much about, again, having a system where cardiac arrest is part of your DNA. And the principle being, if you can get to someone quick enough with a defibrillator, almost every case of cardiac arrest is survivable. You can get someone a defibrillator first minute, it's 90% people survive. So there's that. How do you systemize that, and how do you go near enough's not good enough? Where basically it's that sense of we need to improve that improvement culture, measure and improve a culture of excellence, the 1%ers that make a difference. And importantly, then it's a matter of not getting excited about your survival rates that might be weighted towards the high volume cardiac arrests that occur in urban areas, but actually looking at your rural data and looking at, by local government area and saying to yourself, well, actually, our cardiac arrest outcomes in this community should be able to be, if we create a system effectively, as good as occurring in Melbourne. And I think that's really the crux of it. So cardiac arrest as an outcome in those areas can improve if there's a focus on people actually wanting it to improve, and measuring and improving, reporting your data out there. And there's a healthy competition. I mean, there's a healthy competition between St John, WA and Victoria, I can assure you. And yet you sit there and go, a state the size of WA with 40% survival, and we're actually leading the pack last year. It's because they have that built in. They have first responder app, really significant numbers of community responders. And I think that's where the biggest challenge is. That Denmark, which has some of the best cardiac arrest survivals, I think might be number 2 in the world, compared to King County, has over 100,000 responders attached to their app, has a plethora of AEDs distributed. We've got Victoria around 16,000, 17,000. That's very impressive. But, of a population of 6 or 7 million, how do you get that up there to get a few 100,000 people? When you do that, when you saturate, then you can get an outcome. And that saturation can be by community as well. So you can be in a rural area and saturate that community with AEDs and with people trained, connected to good SAM, you get good outcomes.
You talk about that kind of high level strategy. And when you think about the kind of future ambulance, and you think about, bridging that gap through innovation and real collaboration, what does that kind of look like to you? How do you think we're going to do that into the future?
I think the days of ambulance services saying we've got this are gone. In the sense we can manage this and we can make this work. The reality is that partnering and collaborating is actually the future of ambulance services. I mean, you were seeing that in your previous roles. Yeah. The days of sending an ambulance out to every case is no longer the way ambulance services run, and can't continue to do it that way. So if you're therefore, you're like triaging people via various pathways to the right care at the right time, the reality is the people who provide the right care at the right time are your partners, and aren't in it necessarily. It's about a relationship. So how do you work together to do that? So you do that through secondary triage and the work that you've been intimately involved with in driving to see increased pathways where you can refer more people safely to those partners, if you like. Then comes in the conversation of community. And so your community is a partner. So how do you work with your community to actually understand what to do in an emergency, what number to call, how they can volunteer to be part of the system, either as a volunteer ambulance officer in many rural areas, or as a first responder as part of a good SAM type system. How do you engage the other people in the community, like remote area nurses? They're operating in that community independently of ambulance. How do you bring them into the system? Yeah. So they bring that high level advanced life support care to what you do. So it's looking for those things in those communities to collaborate and to improve your response, because you can't do it by yourself. Fire services, I am absolutely amazed that Victoria is the only state around Australia and territory around Australia where fire services are formally responded as a system responder, co-responder to cardiac arrest. Now, I know others would say, we've got defibrillators on our fire trucks and they can respond, but they're not automatically responded to suspected cardiac arrest. That shaves 2 minutes off response. Now, if I went to our government and said, I want to shave 2 minutes off our response time, it would cost millions and millions of dollars. So for me, it's for who are the other people in your community? Police, particularly in rural areas, often have police services. Why can't they carry AEDs and respond? And other parts of the world they do, and they do it very effectively. So I think it's, again, who are your partners? Who can be out there and not trying to own it all yourself? You're a system. You're responsible for the system and if you like, ensuring that the various pillars are in place, but then it's about working with others to deliver the outcomes, and community and other partners are critical to that.
I think that's great. I promise you, Hanwei, I didn't set him up to talk about my previous work. It just came out well.
And my previous work.
That's right, yes. I was thinking that as I said, it's right. It's exactly right, yes.
It was funny recently when we were chatting around secondary triage and Hanwei was saying, when he was the first person to take the first ever call in Ambulance Victoria. And then he said something, you made a comment about 10 people and the size of the room. And I said, have you seen the building recently? And he said, no. I said, we need to get you in. Yeah. And I think one of the big things here now, you talk about that connected care. And then the big part about that innovation is that sometimes innovation is having that kind of thought and it can be bold, but feeling okay to progress with it. And I think that was what especially Ambulance Victoria did back when you did it, Hanway, when secondary triage. People, I think, I heard about AV secondary triage in the UK and we all thought you were nuts. And it kind of drove my entire passion, for in health and across ambulance. But look what's happening today with telehealth and video triage. And Ambulance Victoria have just celebrated 1 year of video triage.
Fantastic, yeah.
Something they told me that we'd never achieve. So it's amazing.
Tony, I just want to go back to using police and fire as co-responders. We know there's a bunch of industrial role delineation issues that Victoria successfully overcome.
Yep.
I know the early days were quite interesting
Yes.
at some locations. What recommendations have you got to sort of overcome those sort of real barriers in some of the other states to get that co-responder model happening?
So first thing for me is that you need to pay them. So this is part of their job, and it's a different job to what firefighters often sign up for. So often the barrier is that people go, well, they expect them to do it within their normal role. So in Victoria, there were negotiations that led to industrial allowances that made it recognised the impact this has. And I've got to say, impact is significant. I mean, fire services now are doing more in Victoria, doing more EMS calls than they are doing fire calls. We shouldn't underestimate the psychological impact on people who are responding to cardiac arrest in ways that, in Victoria, paramedics would likely to see cardiac arrest once or twice a year. Firefighters may see them more often because the reality is that's what they're getting responded to constantly. So I think importantly, it's engagement. It's understanding this is a professional role for firefighters, and their unions and others believe that, and I support that. So therefore, what are the qualifications they require? We may have views, well, that's not what's necessary. Well, I think it's a negotiation. If you're wanting to bring them on board, it's about recognising that this is about a professional uplift for firefighters, and therefore, how do you support them to recognise that? So I think that's one of the first things, and that certainly was the work that Victoria did, not me. People before me like Karen Smith and Greg Zasella and others had done that work to get those things up and running. I inherited, if you like, their excellent work in those spaces. So I think that's a really important thing. And I think then demonstrating the benefit, showing the benefit that's out there. And I think that's probably through the lens of fire services. With police, it's a lot different. I mean, they're incredibly busy. The police are doing a lot of calls today, mental health and other things that arguably should be the responsibility of ambulance services and other health services. So they're naturally cautious about taking on another role. But I think if it's properly limited and saying, well, actually, we don't expect you to do it in a big urban area, the system should support that with how it works now. But in a small rural town where you're the local police officer and you may be the only professional responder in that actual town, why wouldn't we set up a system where they could carry an AED and be co-responded by the dispatch centre in the event of a cardiac arrest? And I think if you create those boundaries and recognise that this is I won't say last responder, but it's not something you're going to be doing every day. It's going to be a rare event. Then I think that can make a difference. Same with volunteers, firefighters. In those communities, Good Sam has maybe replaced the need for some of that in some communities, but equally, working with those firefighters who are by their nature volunteering in the system because they want to support their community are equally happy to support cardiac arrest response because their neighbours, their friends, their own family. That's why people volunteer in rural areas. How do you create a system that enables them to do that? Doesn't become chance or someone ringing a friend up the road. It's actually, if I dial 000, I know in my community that responders and the system will respond. It might look different to what it looks like in Melbourne or Sydney or Brisbane, but it's still an effective response, providing good CPR, early defibrillation, and therefore the best chance of an outcome.
If you can make one big reform, something in the reform agenda or something you think that would get a positive outcome, do you think it would be something around access to AEDs or more around that actual system coordinating connection with different emergency services? What do you think would be the one? Is there anything you think, if I could be king for the day?
Yes, if I was king for a day, every state and territory in Australia will be signed up to a first responder app.
Yep.
Now, I'm being agnostic in the product because I've seen how effective St John WA's app is, and it works very well. I mean, there's a part of me that thinks, wouldn't it be wonderful that you could cross any border in Australia and it doesn't matter where you are. Now, we can do that in Tasmania and Victoria and New South Wales and And in New Zealand and South Australia, Good Sam recognises you when you cross those boundaries. It would be great to see every state and territory have access to a first responder app, first of all. I think, therefore, what you've got is an ability to then say, well, now we've got the ability to put volunteers onto that system. So it's not a chance. It's not someone calls another number, as I mentioned before, is people having that app on their phone and being able to sign up to respond. And then you need to grow the numbers in those communities. You need to have AEDs within 3 or 4 minutes of where people are. I'm excited by work underway in the rollout of ultra portable AEDs.
Yeah.
I think they're early days yet. They're still getting, and we're looking forward to clinical trials coming out from the first trial, looking at that as part of the Good Sam response in Victoria and New Zealand. But I think things like that are the next level. So technology, Heart Hero in the United States, those smaller, relatively inexpensive defibrillators that can be in a backpack and people could have sitting on the wall at home. Well, all of a sudden you're changing your whole approach to cardiac arrest, where you're not having to head down to the local post office for the $3,000 defibrillator sitting there. I'm not saying don't do that, but I think over the next few years, ultra portable AEDs will take us to a new level in access to early defibrillation.
I remember when Tony was heading off on his semi-retirement. I remember somebody asked you, they said, what was one thing that you felt a bit of trepidation or something around? And I always remember you saying about not having a defib in my car. And then you went, I remember.
I did. I went and got one. That's correct. Yes.
Yeah. You said you'd had 20 plus years of Alzheimer's defib.
Yeah. Literally, since it was 20 years of, or actually might be 25 years of always having a defibrillator in my car. And so it was a sense of I felt quite naked without one. So did get one. And it's interesting. Just as a quick aside, last weekend, a soccer game, some poor young child in one of the other teams fractured her collarbone and dislocated her shoulder. And it reminded me I maybe don't have as much first aid gear. So I now have a very well-equipped first aid kit in the back of my car as well. So it's sort of that sense of you got used to things like that to be able to, nothing fancy, just the simple things you need to save someone's life or help in that first few minutes till help arrives. Yeah.
Tony, you touched on the ultra portable defibs, which are very, very different to the old heart start QRs that I loved around the MCG.
Yeah, absolutely.
What other advances in technology or innovation beyond this sort of ultra portable defibs do you see as sort of vital? Is it AI triage, which we know there's some of? Is it drones dropping off AEDs? What? Yeah.
So I think there's the jury's out on some of them. We know drones in some communities can respond quickly, and so I think there is a role for drones. So I think there's emerging technologies that people are playing with, and I think over time they'll be active in systems and will get to evaluate, do they make an impact. If I look at the role of telehealth, I think is critical, and I think telehealth has two opportunities in my view. We're seeing, again, through the work of secondary triage and virtual emergency departments, the ability to bring senior clinicians to a scene, to evaluate a scene, and literally with the ability to video conference straight into someone's home at a point of a 000 call, which would be ideal to the circumstance. You're literally getting first person on the scene. And I remember previous CEO of St John WA, Tony Ahern, many years ago talked about their first responders would be the person at the end of the phone actually starting treatment by guiding people in what to do. So I think telehealth gives us an opportunity to enable us to do more. So you might have paramedics working in isolated rural areas who have the support of senior clinicians and medicos and others to enable them to apply advanced skills that they would not originally do in urban areas. But it allows they become the extension, and they feel they've got that support to be able to do that. So I think telehealth is going to enable both better assessment and better triaging and those type of things and pathways for people to be cared for, and also support clinicians to provide advanced care in some of those communities where, you could say, oh, great to have a paramedic practitioner. We're not going to have paramedic practitioners all around Australia, but we've got brilliant, well-trained AMBOs and volunteers in rural communities with the right training, narrow focus on the skill they provide and backup support to guide them through that. They can do that. And we saw that, when we introduced advanced life support into rural Victoria back in the late 90s, early 2000s. And one of the things people were talking about intubating patients, that was the thing that needed to happen. We looked at the data. The data didn't suggest that. I did a review with George Breitberger, a well-known emergency physician, and what we found was Actually, that wasn't the issue. The issue was people who were not getting effective pain relief. The issue was people who were not getting fluid resuscitation. The issue was people who were dying from chest injuries and tension pneumothoraces. And so the sense of, you have to be an intensive care paramedic to put a chest tube in. No, you don't. You can put a 14-gauge needle through into someone's chest and decompress it. And we saw cases occurring like that. I remember seeing paramedics in those rural communities who go, I can now give effective pain relief to someone, and they work so hard. They were vocationally trained, and this was hard, the arts room, but they worked so hard because they knew they were going to make a difference to people in their own community, and they did with those skills and techniques. So I think it's that sense of we shouldn't limit ourselves to what they can do, because the system can provide clinical governance support to enable them to do that. So I think that's they're probably the key ones. The other really exciting thing for me is what's happening in stroke care. And you look at the stroke ambulances that are operating in Melbourne, again, they're significantly reducing time to early thrombolysis with good outcomes, and for the right type of stroke, for thrombolytic strokes. And they're importantly triaging people and getting them to get that clot removed. So I think that's a good example of, we've now taken a tool that was hospital-based, like monitors and defibrillators were in their first instance. They're now coming out to a stroke ambulance. Now there are, through the Australia Stroke Alliance, trials underway around headsets that can actually diagnose bleeds, miniaturized CT scanners that will be able to go into helicopters and fixed-wing aircraft. Now you're starting to create equity. And you've got the groups like the RFDS who can get out there, respond in a primary response way, the community doing their work and with telehealth and other support, and creating an environment where they can respond out there and start providing a treatment that previously would require someone to go to a specialist centre to get. So I think miniaturisation, new technology, point of care testing, so we'll have paramedics and paramedic practitioners out there with miniaturised tools. Ultrasound now, again, these were big, huge machines. Now you can put them in a backpack and carry them out there as a small tool. Exactly. So it's, to me, it's that diagnostic ability to enable you then to do other treatments, because now the treatment's often limited because you go, well, you haven't got the ability to diagnose. Well, actually, the tools are out there for us to do that. You can provide that extra care. So they're the things that excite me, in the sense of these things bring the hospital environment out to the pre-hospital environment, into rural areas, and then a sense of, well, how do you support the clinician who might do this once every 5 years? Well, that's where telehealth comes in. Yeah. And I think, there's if you look at Google Glasses and those sort of things that are out there, it sounds high tech, but there's no reason at all why a paramedic couldn't be there treating someone with a pair of glasses on, and, having essentially a voice in their ear of a senior physician from somewhere, guiding them through a procedure, all the data coming from their monitor, defibrillator, and everything else, straight live streaming onto to them and into the glasses, so they're all seeing it. Now that technology exists today, and so how do we create that environment where we can apply that? And it won't be necessarily in urban areas; it will be in rural and regional areas, and then enabling through helicopters, fixed-wing aircraft, or large patient-carrying drones, and you're seeing those sort of concepts coming to life now to be able to take people in a different way than highly expensive helicopters. There's technology out there today that has applicability in the next, I would say 5 to 10 years. We'll start seeing some of these things play out.
So, is there something that you look back on and you think, that's the initiative that I'm particularly proud? That's the one that helped really address the Great Divide.
So I worked for a large part of my career in regional Victoria. And so and I was in charge of clinical services and education for rural ambulance Victoria, and worked in southwestern Victoria prior to that. So the things for me were taking skills that were the domain of an intensive care paramedic in an urban area into rural areas would be the first one. So being able to see advanced life support go out, as I mentioned earlier, see salt of the earth, vocationally trained paramedics in those communities step up, get the training, get the credentialing, deliver care in their communities. It was a game changer. The other big one for me is the cardiac arrest system of care. If I look at the work that occurred in the early, Micah implemented defibrillators, in 1972. So, if you're within the domain catchment of four mic units in Melbourne, you had a reasonable chance of surviving a cardiac arrest. Then we're seeing defibrillators rolled out more broadly. And you mentioned St John and the MCG before. The reality is that St John the MCG was an exemplar of a cardiac arrest system of care. And so, it's a sense of actually, when you look at the outcomes there and then you look at the outcomes in Melbourne and rural Victoria at the time, they were chalk and cheese. St John were leading the way. And so it's a sense of how do we systemise that? Lead governments to invest in public access defibrillators, cardiac arrest registries, so you can actually start measuring and improving those things. So I think they're probably the big ones. If I look at the biggest one that I have absolutely no doubt will make a difference, because the data's already telling us this, is the likes of Good Sam. So how do you take your way back to ambulance services when they first form, with groups of members of a community coming together to help their mates at a time when they're in trouble? And that led to volunteer ambulance services, career ambulance services over time. Realistically, the Good Sam is taking us back to the foundations of ambulance services. How do you harness people, part of the Australian mateship, come together to actually help someone in their time of need, and not be an accident that you just happen to be walking past someone, but you get responded to them and have the tools with you to make a difference. And I think they're the things that I look at are probably the biggest things: cardiac arrest management and enhancing the provision of care in rural areas, breaking down that sense of urban metro divide, the haves, the have-nots, because, I had, and a number of my colleagues had a lot of work to do to encourage and convince a lot of people to allow paramedics in rural areas to do what were considered micro-exclusive skills. And ultimately, if we're serious about the patient, and that's what it should be about, then how do we improve, how do we deliver that care to that patient? Intranasal fentanyl volunteers, another example of that. If you live in that community, you deserve as equitable care as possible. What can we use around us to help us do that, and technologies and enabler for that?
Tony, I think you just touched on that a little bit on my next question. How can data and predictive analytics, big data, how can that help support new innovations or help bridge that gap?
Yep. It's a really good question. And I think we don't know what we don't know. And so data helps us with that. Our data helps us understand, what's driving what we're doing. And I think as clinicians, we're quick to a diagnosis and quick to a treatment based on a pattern of what we see. Sometimes we have very quick views of what's driving demand in our services, and data helps us understand that better. By time of day, whereabouts, what's driving it, frequency, those type of things. If I look at cardiac arrest as probably an exemplar in that, and some of the other registries around stroke registries, STEMI registries and others, if you've got the data at the end of the patient from along their journey into hospital, then all of a sudden you can start asking yourself questions about, well, how are we actually going? So all of a sudden, you sit there as in cardiac arrest in Victoria going, we're actually not doing that well. We're seeing 3% survival in cardiac arrest, despite investing in all these defibrillators. Once we established Karen Smith, I have to say, established a cardiac arrest registry here in Victoria, that's changed things. All of a sudden you've got data. You can actually see, well, what is driving cardiac arrest? Where's the points of difference? Why is that community not seeing the same outcomes as that community? They might be lost in big data in the sense of the sort of reporting on your sort of aggregate data for a state or territory. Well, okay, what's different about that community? What can we do in that community that's different? But you can't ignore that community when you've got the data, because it's telling you, it's screaming at you something needs to be done differently. And then allows you to test, to measure and improve, do something. Does it make a difference? As I mentioned before, a lot of this is 1%ers. Data drove the implementation of high-performance CPR at Ambulance Victoria, and that then led to further marked improvement in cardiac arrest outcomes for the state. So you sit there and go, something we take for granted, we all know how to do CPR. Of course we do. We're all experts at it. It's how we feel as clinicians. All of a sudden, technology and data say, well, actually, maybe you're not. You need to, here's where when you can see how you're going and can improve that either in real time or as part of broader training, all of a sudden what you do is use that data to actually drive that improvement and see an outcome.
It's really, really interesting you brought up high-performance CPR, Tony, because, we've all had reasonably lengthy careers in the health industry. Yep. I was an intensive care nurse prior to ambulance. When I did my high-performance CPR training, I was like, what have we been doing?
Yeah, that's right.
Like, I actually felt a bit stupid. It's like, even in one of the leading ICUs in Australia, we were doing poor CPR.
Yeah. And we thought we were doing good CPR.
CPR.
And then you're sitting going, oh, we just need this other bit of equipment. That'll improve cardiac arrest survival. Actually, it's us. That, we're part of the continuum. If we do this, if the call taker can do this differently, if the AED is more readily available and connected into a system, then all of a sudden the things start, those 1%ers start improving. That's that's how Ambulance Victoria and St John WA and other ambulance services around the country are now using that information approach to actually continually improve and not resting on their laurels. You can see the benefit of that, and it doesn't just apply to cardiac arrest. Organisations that focus on improving cardiac arrest do other things better as well, because all of a sudden it's about a culture of excellence, about how do we continually improve. It's, again, not resting on our laurels. And data drives that, because you can't hide away from the data. And I think, the brave thing is when ambulance services report that data. So cardiac arrest registry outcome annual reports to their community, it's critical. And it can be embarrassing. But, in some ways, we're an ambulance service might go, well, my percentage of cardiac arrest survival is just compared to this other state just down the road. But the reality is you've got to start somewhere. So what are they doing differently? And the thing for me around these things is I rarely ever want to be the first person to try something new in technology, but I'm right up there for the second. So someone else is trying new or something new, I'll be right behind them. St John, New Zealand led the way with Good Sam. We were right behind them every step of the way, and kept pushing the boundaries. Well, just health professionals or people trained in CPR. No. They can't go into people's houses. Yes, they can. They're not going to steal the jewels. It's going to be okay. We know who they are. So now it's about just having CPR awareness. It's a sense of any CPR is better than none. Yeah, I'd love someone trained to be able to do it, but hey, I'll take what I can get in those circumstances. So that's the sort of the big driver, I think, yeah.
I just love this conversation about Western Australia, because all I can think is that in this podcast series, we're actually meeting with their medical director. We're going to be chatting to Gail.
Fantastic.
So, there's nothing like this state, little bit of rivalry that we all love. So I think we'll be definitely asking these questions when we get there.
I actually think it's healthy competition is a good thing. And what healthy competition is, you just pop over, look over the shoulder and go, what are you doing? How do you do that? How did you get that happening? And it allows you to go running back and go, they're doing that, and I reckon we should try that, because and they did it and they didn't get in trouble, so it must be okay. And so all of a sudden and there's that. Yeah, I have no doubt. I'll watch with interest to see what the published outcomes will be for cardiac arrest outcomes next year, because St John and AV are neck and neck, and that's saying something in the context of 41%, and particularly for both those states. They're not just an urban area; they are for the whole state, and I think that's an important difference. And I think it's a healthy thing to do. I think we learn off each other, we steal good ideas, and we make them work in our environments.
So, Tony, we talked about the increases of you talked about the increases of the 1%. What does that 1% mean to you in people terms?
Yeah, it's a really good question. I mean, if you look at the data, you can get lost in it, and you can get lost in the comparative pieces we're talking about between services in Australia and around the world. But we're talking about people, real lives. I mean, one of the hardest things for an ambulance service to be measured by is cardiac arrest, because essentially you've got someone who's clinically dead who is alive. And it's not about, when we talk about the numbers, we're talking about real people, young people taken out in often the peak of their lives. And with good cardiac arrest systems of care, what we see is those people return back to normal lives. Nearly 80% of people who suffer pre-hospital cardiac arrest are returning back to their families. 74% are returning back to work. So, we talk a lot about data because it helps us think about the system and measure the system, but we're actually talking about real people who have been returned back to their families, and often in the peak of their lives.
Talking about real people, we've actually got Justine Phillips, who is a cardiac arrest survivor and a recipient of those all-important chains of survival. So we're going to bring her into the conversation.
Wonderful.
So thanks, Hanwei, and perfect timing to add to the conversation. Welcome, Justine Phillips, to the conversation.
Thank you.
So this has been about the Great Divide. We've had some fantastic conversation, I might be biased though, around with Tony. And Tony just really shared about the statistics around cardiac arrest survival are really human stories. And we thought, what a perfect time to introduce you. And it'd be great if you could share a bit of your story with us.
Yeah, absolutely. So I suffered a cardiac arrest at home back in July in 2020. So it was during the COVID lockdowns. So thankfully for me, because Victoria was in the middle of lockdown, my children were home schooling. So they were both home at the time. When I had my cardiac arrest, my daughter was in the kitchen and just had this feeling that she had to come up and run something past me. And she came up and found me on the floor unresponsive. She alerted my son, who was in the bathroom at the time. he came out. So together they called 000, and my son performed CPR until emergency services arrived, which was between the 7 and 8 minute mark after the initial call. So once they arrived, they worked their magic, as I like to say. And at the 30-minute mark, they had to make a call. So I was defibrillated 8 times, continual CPR, the copious amounts of drugs that they provide you once you've had a cardiac arrest. And thankfully for me, because I was showing some minor signs of life, they decided that, they would continue their treatment and transfer me to the local hospital, which is the Frankston Hospital. And by the time I arrived there, it ended up being 93 minutes later after I had my cardiac arrest that my heart started beating again in a normal rhythm. So very thankful and very lucky for the work, not only from the emergency services, but for that early intervention from my children, because if that hadn't have happened, I wouldn't be sitting here today.
How old was your son?
He was actually on his 16th birthday.
Yeah, oh wow.
So, he was 16, had no previous training at school or anything. And that year that he was in school, I believe he would have had some sort of training, but definitely the following year, they had first aid training at school.
Well, you're obviously here talking to us, which is amazing.
Yeah.
I mean, I just got to ask, did your son tell you that you could have got him a better present than learning CPR?
I do get the reminder, the sort of look every now and then that just remember who,
Oh, my word. That's actually great. Yeah. Yeah, as well. Yes.
Justine, it's so interesting that without any training, your son performed essentially, well, it had to have been effective CPR, I think we'd all agree.
Definitely.
Yeah.
Tony, I think that just goes back to one of your comments that any CPR is better than no CPR. Obviously, this CPR was quite good. What are your thoughts on that CPR education for early sort of school age? Because clearly it can make a difference.
Oh, absolutely. I think, CPR is a life skill. I mean, everyone should have it. And there's a strong argument that it should be, taught. Every child should learn CPR at school. I mean, it should be mandatory in my view and many others, because you don't have to be an expert in it. You just need to have an awareness of it, which often then allows the call taker to guide you through when they're saying, put your hand on the chest, you know what that means. Press like this, you know what that means. So I'm sure that's what's happened in Justine's case, that the 000 Victoria call taker has basically guided son to do that, and clearly effectively. So it's fully supported. It's a life skill. Everyone should know how to do CPR. Again, you can argue it doesn't have to be a full-blown CPR course, but everyone should have good awareness and a practice on a mannequin. So in the event they have to do something, they know what that means.
You brought up a really good point, which was remiss of me. 000 Victoria, those true sort of first responders guide lay people through CPR and clear, like Justine, I think you're a perfect example of how important that call taker role is in detecting cardiac arrest, but also providing truly life-saving instruction.
Absolutely. Because without those instructions, he wouldn't have known how to effectively perform CPR until emergency services got there. So, the 000 operators played a huge part in that role of helping a lay person, particularly someone who has had no training.
And Tony, you obviously earlier we talked about, what's those big reform pieces, and you just mentioned there, that's one we didn't talk about, that actually should CPR be something that is taught in schools. I can imagine this is something I may see you on social media, Justine. I've seen that. What are you doing in this space? You tell us.
So after my cardiac arrest, I actually, for me, it was a big learning curve, because I honestly thought cardiac arrest was just another name for a heart attack. And it's not. And they both require different treatment, still emergency treatment, but just different treatment. So after I did my own research, I decided I want to be able to go out there and teach individuals how to perform CPR. So I went and studied. So I've got my training and assessment certification, and I now teach first aid and CPR. My passion is the CPR side of things. And in regards to, talking about children, I've just started doing some programs now where I'm going out to sporting clubs and teaching kids in sporting clubs, this is what CPR is. If you are asked to perform CPR, this is how you do it. And, they learn on the mannequins, and we have a discussion about it. And, at the moment it's the teenage children, but my passion is to get into the younger ones and just make sure they know even to call 000 in an emergency and work from there. And, we don't have to scare our young ones. It's just giving them the basic knowledge that they know that, call 000. If you need to perform CPR, this is how we do it.
I think, Justine, you touched on something that Tony mentioned. Cardiac arrest care is not just an ambulance issue. It's right across the community. Your work with some sporting clubs, St John does first aid in schools. In terms of that CPR education, Tony, what are some of the other things to support or advance sort of Justine's work in that area?
Yeah, it's a really good question, because how do you reach everybody? How do you reach, and that's often the challenge. And I think we talked earlier about technology, and there are really interesting apps out there now that can teach people to do CPR using a cushion or a relatively inexpensive mannequin in their home, and can measure their actual compression depth and can guide them through it. So I think there's Lifesaver program in the UK is a good example of that. So I think there's a role for technology to say, well, we want, in the perfect world, everyone can do absolutely perfect CPR. That's what I think we all, and the work Justine's doing in formal training, that I think is absolutely critical. But then how do you go, but if they're not doing that, how can we have a baseline where everyone is able to do a simple course they're aware of, as Justine said before, this is what CPR is, this is the number you call, this is how you do it. If every member of the community had that skill, and then, ideally then said, well, actually at the same time, would you like to sign up for this app? So if someone nearby needs your help, you can do it. Then you start seeing real change. So I think, again, it's technology. Technology can help us not replace a practical skill like CPR, but enhance it so that there's a baseline understanding for every member of our community.
Yeah, I think that's some great points, isn't it? And Justine, from the work that you're doing, is there one thing that you think, if I could make one change today, what would it be?
The big problem I sort of notice out in the community is that people don't really know a lot about cardiac arrest. So it's the awareness about it and just what treatment is required. So it's sort of breaking down the barrier in regards to what cardiac arrest is. Because like most things, and I'm the first person to put my hand up, I am very naive and will not look at maybe other illnesses if it doesn't affect me directly. Whereas, now I can sit here and say, look, I've firsthand seen what cardiac arrest can do and how it affects those around you and so forth. So, trying to knock down barriers is the biggest thing that I see out in the community. So, having apps, as Tony said, using technology where, people don't think, I've got to go do this first aid course to learn CPR. Like, people might not be comfortable in a group setting and so forth. So, having some form of technology where they can just get on the app on their phone, watch a video, practice on a cushion or a pillow or a teddy bear. So that would be, fantastic to see. And hopefully, it encourages more people to step out of that comfort zone and help someone within the community or a loved one.
Yeah.
Justine, I think you raised a really good point, and it's something we haven't covered in the discussion yet today, but it's a really important one because women have a lower chance of survival from cardiac arrest. And the studies have shown that that's partly due to people's concern about not wanting to touch a woman's chest or expose a woman's chest. Justine clearly had effective CPR from someone. I guess I'd open up to both Justine or Tony. What are your thoughts around that topic?
I guess for me, speaking from my experience, is one thing I do in my sessions that I teach with CPR is I have these little breasts that I can put on my mannequins and can remove if need be. And it's just pretty much just saying to people in the session that whether it's a male or female, it's irrelevant. That person needs life-saving attention right now. And that's what you need to think about. This could be your mother. Just think of it as a mother or a sister and step in and do what you would do if it was for them.
I fully support what Justine's saying. I think it is about having life like mannequins so that essentially people feel comfortable and flagging the reality of this is, you're not going to do any harm. It's a real challenge often for people putting defibrillator pads on, and I think for AEDs. So, there's a lot of conversations going on. Do you need to remove the bra? Can there be different modifications? So if these are real barriers, then research is underway to say, well, actually, how can we potentially change some of the approach so that the barrier can be overcome? But I think if it starts with practicing on mannequins that are lifelike and will show breasts. And I think importantly, hearing women talk about this issue is critical, because ultimately it's one thing for a guy to be up there talking about it. It's a different thing, particularly for cardiac arrest survivor. So, well, actually, I was fortunate because my son did it, but, I could be in the street and someone, the evidence would suggest maybe someone might hesitate, and we don't want them to hesitate. And that sense of, again, it's like that awareness, it's going to be okay. You might feel a bit uncomfortable, but you're going to save someone's life.
But also educating the public that, there is the Good Samaritan law out there, that if you step in with the intent to help save a life, there's going to be no repercussions if you're working within your scope of training and you're within your knowledge. As long as you're not trying to be a doctor or a lifesaver and do more advanced techniques and procedures and so forth, if you're just stepping in as a lay bystander, you've got that Good Samaritan law there that protects you from anything like that.
Yeah. And I think, I've been to so many cardiac arrest patients who, are women. And when I've arrived in the public, nobody's doing CPR. And I'm like, I can remember one walking into a high street of a busy town and people were looking at her. And I got straight down and I asked at the end, I was probably a little bit short. And I said, why didn't any of you start it? And they said, because we didn't know what to do with her bra. And it was the bra was this thing. And I was thinking, cut it off and expose her, And it's that not understanding. So I think talking about it and doing things like this is where it brings that awareness. So I think it's really important. And I think with people like Greg Payne, who obviously the Wiggles have, doing a lot of work, and yourself, and Tony, you're out with the Alliance talking about it. And, it's kind of a global conversation. I mean, I think that's great. And starting young, I just got to say that as a mum of a young toddler, I already have, we have paramedic Amy Gomez from Queensland, she's written a book about what paramedics do. And, I have it on my bookshelf. My 2-year-old is already getting read it and is talking about CPR. And, I think that's great. Start early.
Absolutely. Just bring down the barriers early and just make it an open conversation.
Justine, I think, thanks for giving us your perspective on as a cardiac arrest survivor on CPR in a female. I think that's really, really important for us all to break down those barriers. If there was one thing that you could do in terms of cardiac arrest care for the public, for responders, what would it be?
It would be just learn CPR, go and do a course, because that could be the difference between the life of a loved one or the passing of a loved one. And by just educating yourself, you've got the knowledge and the skills. And if anyone is ever in that situation, you know that you're doing the best that you can with the skills that you've learned. And just for anyone, it doesn't have to be just a loved one, just step in.
And I think for me, bringing you in, Justine, has really just reinforced that the importance. You're a living example of all those components of the chain of survival working in concert and working well, which brings us to the end of this episode. So today we explored the contrasts in cardiac arrest care between rural and urban communities, from early CPR and AED access to community engagement and the role of innovation. A huge thank you to our esteemed guest, Tony Walker, and to our fantastic cardiac arrest survivor, Justine Phillips, for sharing your really valuable insights and experience. Ambulance Insights is presented by Corvanta, Mission Critical Technology, and the Council of Ambulance Authorities. If you'd like to see who's coming up next, although I think Lindsay might have given you a sneak preview, head over to corvantakit.com. Until next time, stay safe and stay connected.
Thanks all.
Thank you.
Thank you.
Thanks.